Bismillahirrahmanirrahim.
डॉक्टर तौसीफ कमर साहब लाहौर से स्पेशली तशरीफ लाए थे। मैं जैसे पहले अर्ज किया है ज़रूर एक्नॉलेज करना चाहूँगा फार्मास्यूटिकल कंपनीज, IQ और अल्फला सर्जिकल वाले जितने भी हमारे दोस्त और पुलिस हैं जिनकी स्पॉन्सरशिप से, जिनके ताउन से हम ये कहते करते हैं। और मैं मिड ऑफ द सेशन में ज़रूर चाहूँगा कि ये जो आप रंग देख रहे हैं कॉन्फ्रेंस के, जिस शख्स की सबसे ज़्यादा मेहनत है मैं उसके लिए भरपूर तारीफ चाहूँगा, डॉक्टर अब्दुल हफीज़ सखानी साहब, जिनकी भरपूर कोशिश से हम इस किस्म की महफिल सजा पाते हैं। अब हम अपने अगले स्पीकर की तरफ चलते हैं। मैं आज हालात की दहलीज पे बैठा इस सोच में मुस्तगरिक हूँ कि इल्म अदब के इस पैकर, खूबियों कमाल के मुजस्मे, सीरतों किरदार के मुरक्का, उस्तादों के उस्ताद जनाब डॉक्टर दुरे सबी साहब को आज कौन सा खिराज तहसीन पेश करूं। मैं शायर होता तो हरूफे बेतरतीब को पैकर सुखन देता, ज़ौक़े मौसीकी से शनासाई होती तो साजो आवाज का जादू जगाता, और अगर फन नुत्क़ का महर होता तो बेदरे किताबत के लौहक उठाता। मैं शायर हूँ, ना मुसव्विर हूँ और ना ही मुकर्रर। एक तरफ ज़ख़ीरा अल्फाज की आजिज़ी का एहसास है तो दूसरी तरफ दरिया को कूज़े में बंद करने से हुनर से मुतलकन बेखबर हूँ। मैं आप सबकी तालियों में आज के हमारे जो लोकल और सबसे बड़े स्पीकर हैं जनाब डॉक्टर दुरे सबी साहब, उनको रिक्वेस्ट करूंगा कि वो स्टेज पर तशरीफ लाएं।
बहुत लंबी लंबी छोड़ी है। Where you are not sure of what is happening. It's very easy if you picked up something significant, something obviously wrong with the baby, and you can say that, okay, this baby is not going to survive, or this baby is going to be severely deformed or severely abnormal. And it's very easy to reassure the parents saying, okay, we have a perfectly fine baby, I can't see anything wrong with the baby, so we hope that you're going to have normal delivery. But then there is a big gray area or orangish, greenish area in between where you're really not sure what to say. And the questions are to yourself, and this is something that you want to communicate to your gynecologist and to the parents. How significant or how bad is it? Should I say anything, or should I just keep quiet? Should I write it in the report, or again should I keep quiet? Is he going to come back and bite me if something terrible happens to the baby, or what? Or am I going to cause an unneeded intervention? So that's a very important question. And I hope that we will be able to deal with some of these subtle findings, and we'll be able to come to a conclusion about how to deal with those. Okay, so this is the list of things that we are going to speak about. You're obviously looking at all of these things, but what happens when you find one of these things, and what do you do to the patient? That is the important question that we are going to try, and we're going to... Right, so some of these things are already included in guidelines. They're either in the AIUM guidelines or the ISOD guidelines. Some of these you know as soft markers. But what happens when you find those? And that is something that we are going to talk about. Okay, ye kya hai? What is this and what needs to be done? Those who were here in last evening's workshop have already seen these slides, so they might get bored for the next 5 minutes. But for the rest of you, I want you to tell me what this is and what would you do when you find it. What is this? First question. Sorry? Nuchal translucency. This is increased nuchal translucency. What would you do when you find this? If you found this, what would you suggest? What would you tell to the parents? What is the next step? जी? Anomaly scan. तो आप अगले 6 हफ्ते उनसे कहेंगे इंतजार करें. Sorry? You have to speak a little. I'm old and I have weak ears, weak eyes. You have to be a little louder. So, do you ask for an abortion? Do you ask for a CVS? Do you ask for a CVS? Okay, all right. So nobody does a CVS here. At least, I've done about 1,200 CVSs, but they were all for thalassemia, and I don't remember getting a request for CVS for suspected aneuploidy. But yes. So what is increased nuchal translucency? You see, every fetus has a nuchal translucency. That is something that is normal. It is only when it is increased that it becomes significant. You measure this between 11 and 13 plus 6 weeks. If it is increased, it is associated with an increased risk of problems. And those problems are trisomies, heart defects, and lymphatic obstructions. If your nuchal translucency is 3 millimeters, about 10% of your fetuses are going to be abnormal. If it is 6 millimeters, about 90% of your fetuses are going to be abnormal. But let us put it into context. What happens to nuchal translucency? If you have seen increased nuchal translucency, it can progress to cystic hygroma or it can resolve. Now that is an important point that you must all remember. Increased nuchal translucency can resolve with time. So if you're not habitually doing a first trimester anomaly scan, you are probably missing a lot of cases which would have been abnormal at 13 weeks and you could have done something about it. And so that is one of the reasons why a first trimester anomaly scan is important. So it can become converted into cystic hygroma or it can resolve, and that is the important point that I'm trying to make here. This is a list of all of the things that can go wrong. Includes at the bottom of the list can be a normal situation. You can have a nuchal translucency in a completely normal embryo that is chromosomally normal and anatomically normal also. So what do you do when NT is increased? Somebody has already suggested that we go for chorionic Villus sampling. Although truthfully, I don't think many of you. How many of you have ever asked for a chorionic Villus sampling when encountering an increased nuchal translucency? Anybody? Nobody. Right? It is important to do that. Why? Let us look at this study. It's about a 6-year study with a very large cohort. We have about 675 fetuses in which there was increased nuchal translucency, and they did a chromosomal analysis in all of them. And about 33%, 1/3 of these fetuses actually had chromosomal abnormality. That means about 2/3 of the fetuses were normal. Those that had chromosomal abnormality were dealt in that manner, and those who had no chromosomal abnormality went on for a routine second trimester anomaly scan in 20, 22 weeks, 18 weeks, something like that. Of these, 88% had a normal anatomical scan. So a majority of these patients had normal anatomical scan. And about 12%, about 10% had something abnormal that you could pick up on second trimester scan, and then you could deal with it according to what you have picked up. Of these 88%, 96% went on to have normal babies. Right? So having an increased nuchal translucency means that there is a certain risk of having an abnormal baby. If you cannot find an abnormality, there is a very high probability that you are still going to have a normal baby, and you need to understand these numbers, and you need to incorporate this knowledge into your management of. So the conclusion was that after you excluded chromosomal anomalies, about 20% fetuses will still have an abnormal outcome. But the rest, the vast majority of the fetuses that are left behind are going to be normal. So that is how you deal with increased nuchal translucency. If you can do a chorionic Villus sampling, that's fine. If you're not going to do a chorionic Villus sampling and rely on a second trimester scan, you're exposing yourself to use his word, a pitfall. And that pitfall is, please remember that ultrasound will not diagnose all cases of Down syndrome, trisomy 21. Please remember, trisomy 21 is the commonest chromosomal abnormality. And how common is it? What is the incidence of Down syndrome? Sorry? Any age-related terms, we are not baseline view. It's about 1 in 800, so it's a very, very common problem that you can have in a young population. And it is very important for you to be able to diagnose this. And ultrasound has a sensitivity that varies from about 80 to 90%, which I think is inadequate when you're dealing with something that can be as significant as Down syndrome. So what do you do when NT is increased? Okay, we are just recapitulating what we've already spoken about. You do a chorionic Villus sampling. Those of you who do not do chorionic Villus sampling should try to do chorionic Villus sampling. You can send it to Aga Khan, or you can send it to NIPG. It's very easy to transport chorionic villi. You just put them in a vial with saline, no special preservatives. And DNA, like a DNA, the bomb site se bhi nikal dete hain na, exposure se bhi. So DNA is very, very tough. So you don't have to worry about temperature control or any such things. Just put it in a vial. You send it to Dr. Shahid Beg at NIPG, and you will get a chorionic. You get a karyotype done in about 2 or 3 weeks. So and they take about 5,000 rupees. Aga Khan will take anything from 12,000 to 20,000 rupees, depending on what their needs is. It's fresh or something, or karyotype or something like that. You don't really need a TVS. Those of you who do not have a TVS need not despair. If you have a transabdominal facility, only you just need to see your patients a little later in the first trimester. And so the red bar is the TVS. So you really need a TVS if you're dealing with a very, very small embryo, which is not a good idea anyway. If within this window of 11 to 13 plus 6 weeks, try to get your embryos as late as possible within that window. Because at 12 weeks, in a lot of cases, your nasal bone will not have formed, but probably we're going to talk about these things. Your cranium will not have calcified. So you're going to miss some really good opportunities of making a diagnosis. If you're looking at your embryos, your babies, very early within this 11 to 13 plus 6 period rather than later. So try to go as late as possible, ideally about 13 weeks. So if you have only a transabdominal ultrasound, you should be able to do about 80% of nuchal translucencies at about 13 plus 6 to 14 weeks. Anyway, but if you have both, of course, then you are that much enabled to do a more complete examination than if you have only TBS or TAS. Okay, this at one time was the best nuchal translucency scan in the world. This was published in Time magazine. and this was published by, and this scan belonged to a very dear friend of mine and Fazil, Alan Waddle, and I'm very proud to be his friend. And here I am with Alan Waddle. He passed away a few years back. He was a personal friend. I stayed at his place a number of times. And he was the most generous person with his time, with his knowledge. And this is another great ultrasound person. This is Dr. Ravi Kadasne. He's an Indian who lives in Al-Ain. And I call him the Michelangelo of ultrasound. The images that he picks up, the images that he creates, Ravi Kadasne. You can find him on Facebook, you can write to him. But that is a work of art. What he does is a work of art. And I think he has improved my scanning ability by just seeing the sort of things that he's able to do with his ultrasound machine. He is simply brilliant. This is about 3 years back. Okay, so nuclear translucencies, normal, we don't know. Why? We don't know. Why? Because I'm not sure if this is the skin of the fetus or if this is the amniotic membrane. Is the nuclear translucency here or is this one the nuclear translucency? And we're going to talk about it, how you can ensure that what you're looking at is the skin and not the amniotic membrane in a little while. If your nuclear translucency is associated with other abnormalities, the chances of having an aneuploidy increase exponentially. I was looking somewhere, by the time you get about 5 anomalies in a fetus, the chances of an anomaly are almost 100%. But if it's an isolated case, your chances of an anomaly are about 10%. If it's 3-4 millimeters, not too much. In this case, you have not only an increased nuclear translucency, fuzzy, इसका वो नहीं चल रहा है. Can I have? Oh, okay. No, I cannot use this. It's not displaying. इसमें ये नहीं चल रहा. चलिए, okay. So only will not do. Needs to be here. And escape करें. नहीं यही यार, ये दोनों चीजें हैं. हाँ भी. ये किसका है? नहीं आप शैडो नहीं स्लाइड. अच्छा. Okay, we can probably extend the screen on the second screen. Let's try the second screen. Okay, we can work with this, I suppose. It's not a problem. We can work with this.